Hi, good afternoon, everybody. Welcome to the ANTHC Burn and Soft Tissue Echo. My name is Dr. Alicia Brownson, and I'm the Trauma Medical Director here at Alaska Native Medical Center. Please mute your phones and pagers to minimize disruptions unless you are contributing during discussion time or need to ask a question. For those of you participating by VidYO, you may also use the group chat function. Today we will have a brief didactic presentation followed by a case presentation and discussion. CME and CEUs are provided for this event. Please email or look on the ANTHC website for details. Today I will be our didactic speaker and I will be presenting on skull burn. If you have any questions or ask about today's didactic, we will have an opportunity to ask them at the end of the didactic. So we're going to start on a presentation on skull burns, and you can follow along with the slide deck here. First, we'll talk a little bit about the scope of burn care in Alaska. Since this is our first burn and soft tissue echo, I thought I would give an overview of kind of the scope of the problem here in Alaska. Then we'll talk about burn wound basics with assessment of the burn wound, and then specifically skull burn patterns and management. So there are about 100 burn-injured patients admitted to Alaskan hospitals each year, but this is just the patients that end up being admitted to hospitals. So we know that many more are seen in emergency departments and clinics, and so that number is much larger. Here at Alaska Native Medical Center, we admit about 25 burn-injured patients each year. Most burns that we see here at ANTHC are not transferred out. They're kept here and cared for. And so this is a summary of burns that we're seeing over the last 4 years. And from the years 2015 and 2017, most of these burns were small, moderate, less than 20% TBSA. And so you can see our total burns in 2015 were 26. We transferred 3 out. And then most recently in 2018, we had 32 burns and 3 were transferred out. So most burns are actually kept here at ANTHC that we initially evaluate. There's a lot of challenges to burn care in Alaska. These are really high acuity injuries, but we don't see them that often, so there's low volumes. There's a lot of specialty care required in burn care. Here in Alaska, we have 2 level 2 trauma centers, which take the burns here in the state. But our regional burn center, our first burn center, is actually in Seattle at Harborview Medical Center, and they're also our level 1 trauma center. So geographically, our specialty care is very scarce in Alaska, which makes burn care difficult. There's also a lot of issues involved with transport, whether it be the cost of the aeromedical transport, the distance it takes to get patients to this kind of care, or the weather challenges that our transport has. So the goal of this burn echo is to facilitate a multidisciplinary approach to burn and soft tissue injury management through shared learning. And this is to improve the existing burn care of patients in Alaska with our ultimate goal here at ANTHC, striving to keep the Alaska Native population the healthiest people in the world. So we'll start to talk about burn wound assessment, and this is really important as we begin our burn echo series to really talk about the common language for burn providers. So how to describe burn wounds, and we always want to include the 4 descriptors: size of the burn, depth of the burn, location of the burn, and mechanism. So for example, in the photo shown, we would say this is a 3-year-old boy with a 9% TBSA, or total body surface area, partial thickness skull burn to the chest and abdomen. And that really gives the providers on the phone or across the video a really good description of what we're dealing with. So we'll talk about size. So again, TBSA stands for total body surface area %. And many of you may be familiar with the rule of 9s, which divides an adult body into integrals of 9. However, for children, the measurements are a little bit different, so you'll need to make sure that you use an appropriate chart that's age-specific. For small and some medium-sized burns, often the Palmer method is better, which is the patient's palm, and wrist crease to fingertips would be 1% of that patient's TBSA. So if a smaller burn, you can kind of estimate that way to look at burn size. Talking about depth, we'll talk about first, second, and third degree. The first is first degree, which is a superficial burn. and is not included in the total body surface area calculation. This is because it's usually not clinically significant, will not require hospitalization, will not require surgical care. This wound will be red or erythematous, but there will be no blisters. A second degree can be divided into either superficial partial thickness or deep partial thickness, but the characteristic of a second degree burn is blisters present. And so if you see blisters, that's a partial thickness burn wound. When you debride those blisters, what's underneath determines if it's superficial, which would be a peak and moist wound bed, or deep, which would be still moist and blisters present but more pale. And then third degree is full thickness. This is dry. As you see, it's flat. You don't see any blistering. And often there's lack of sensation. So if someone has a large burn and they are very comfortable, that should be worrisome for a third degree or full thickness burn. And there's many colors to third degree burns. You can see white, that dark brown, the picture on the bottom left, and that red. That's a third degree scald burn. And so there's many different colors, so look for that leathery, dry appearance. Location, location, location. It's important to note location, especially noting specialty areas. So face, hands and feet, groin, or major joints. Also, if someone has a hand burn, we want to know if it's their dominant hand, and also if it's on the dorsal or palmar aspect, because that affects what kind of treatment we consider. There's lots of ways to get burned, and so they're listed up here: contact, scald, slash and flame, specialty burns like electrical, grease, chemical, friction, and inhalational. But today's talk will focus on scald burns. So scald and steam burns occur when skin contacts a hot liquid or steam. So think about hot water, hot beverages, hot food, or steam. And typically these are in a spill or splash pattern because it's usually contact with this liquid. It's actually the #1 burn mechanism in children ages 0 to 5. Once you get in the older children, they tend to start playing with fire, and so it switches over to flame burn mechanism. But this is very young children that typically are involved with scald burns, and actually 1/3 of all burn hospital admissions are due to scald injuries. Next. The length of contact with the offending agent and the temperature of the offending agent are what affects the severity of the scald burn. And so here you see water temperature, and you see the time it takes for a third degree burn to occur. So to put it in perspective, it says 100 degrees is safe temperature for bathing. 110 would be like a hot spring type of temperature, like China hot springs. A Starbucks coffee is typically at 140 or 145, so it doesn't take very long to have contact with that to cause a very severe full thickness burn. And if you're talking about boiling water, it can take a second or less for that to cause a full thickness burn. Common sites of scald injuries, so often these occur in the kitchen or dining area. Think about where you're in contact with hot foods and hot liquids. So you can have spills. Also, in Alaska, we have to consider there's a lot of places without running water, and so where we're heating water, maybe open boiling pots on stoves, that can be a risky area for scald injury. Also, scald injuries can happen from bathing, and so this could be often children or elderly are more prone to this. But you can have a scald burn if they're unable to remove themselves from the hot water or tell that the water temperature is too hot. Non-accidental trauma is something we have to consider with burn injuries, and so these are some characteristics for when we are concerned that there may be, that these may have been intentional injuries. If the pattern's not compatible with the history given, inconsistent story, or doesn't match the developmental level. A big thing with burns is that there will be a smooth line of demarcation, like a glove or a stocking pattern. The picture on this slide shows a patient that was held down in a bath. And so you can see the soles of the feet and the bottom of the buttocks were spared because they were on the cold tub. And you see that clear line of demarcation where the patient's skin was in contact with that tub water. Other things that you may consider is if the caregiver was absent, if there was a delay in seeking treatment, if the child seems withdrawn, or if there's other associated prior injuries. And again, children, elders, and people with disabilities are at risk for non-accidental trauma. So scald burns are often a mix of both superficial and partial thickness burns. Immersion scald burns, again, immersion typically indicates longer time in contact with that hot liquid, so those can be deeper partial thickness or full thickness burns. But most of them are going to be superficial and partial thickness burns, and so most scald burns can be treated with good wound care and will not ultimately require skin grafting. Burn wound debridement can be performed by any healthcare provider. It's important to note that the debridement is usually guided by MD or DO, nurse practitioner, or physician assistant, but it can actually be performed by any healthcare provider. It's very important for wound evaluation. So the pictures you see on the slide show wounds before and after debridement, and the picture on the right, we really get the full picture of the depth of the wound, the size of the wound, where before, when it was not cleaned and had blisters present, we weren't able to fully evaluate the wound. The other thing is that removing those blisters provides access to the wound bed, so we can provide therapeutic care for the burn wound. So to perform a burn wound debridement, often the best tool you have is a washcloth. If you use a firm white washcloth, you're able to get most of those blisters off. Then you can trim the skin edges. You can lift them up with forceps and just trim them off with scissors. And that's able to create most of your burn wound debridement. You don't need any surgical tools to be able to do that. So what are we doing for burn wound care? For first degree or superficial burns, we want to put on these wounds fragrance-free moisturizer. We typically say not aloe vera because the over-the-counter aloe vera is typically alcohol-based and dries wounds out. The actual aloe is helpful for wounds, but most over-the-counter solutions are not helpful. We want to discourage any home remedies, and again, just a fragrance-free moisturizer should be all you need. Usually these do not require surgical follow-up. For second-degree superficial burns, really what you need is a topical antimicrobial and some kind of greasy gauze. So whether it be bacitracin or neosporin, some kind of topical antimicrobial, and then you're going to put whatever kind of greasy non-stick gauze that you have to put on top of that. Deep partial thickness burns, you may use silver sulfadiazine, or we often abbreviate that SSD. You may use that to deeper wounds, but again, we want to transition early to bacitracin or topical antimicrobial. Once you see the skin buds, so the picture on the right, you see a white wound, that dark, that pale, moist wound, that's a deep partial thickness. So you see those skin buds starting. That's typically when we talk about transitioning to bacitracin, as the silver sulfadiazine impairs epithelialization, so you'll get better wound healing once you transition out of that. Next slide. Third degree or full thickness burns should get the silver sulfadiazine. It penetrates the eschar for full thickness burn wounds and will be a better topical agent for full thickness. The other important thing is that any full thickness burn should get a surgical consult. And so we want early surgical consult for that. The other thing to talk about is we are now using a lot more of silver impregnated dressings. So for example, here at ANTHC we use Methylex silver, and those can be used. They're best for second degree burns. They don't require daily dressing changes, which is a really big factor often for children for avoiding pain for daily wound care. But you can't bathe the child. They have to be, that surface has to be kept dry, and so you have to kind of have a discussion with families about if that's a dressing appropriate for them. It's better for flat surfaces, harder to put on like joints like elbows or hands, but this is a scald burn that has a chest injury, and so that's a nice flat surface, and so you can put the Methylex silver on, and after 5 to 7 days take it off, and often that burn wound is healed by the time you take it off. You can see there's the silver dressing being placed on that chest. Next slide. And that's lightly secured in place with even no tape on this child. Next slide. And this is the first clinic visit 5 to 7 days later where that is completely healed, and now that child can transition to lotion. So this can be a really great option often for, again, these scald burns that maybe that spill pattern that are partial thickness. Burn injury prevention has to be talked about with a lot of scald burns because many of these burns can be prevented. So different scald prevention can include making sure that the hot water heater settings are not too hot in residents. Also putting boiling pots of water on back burners or away from reach of children. Turning those pan handles away from the stove front, again, so they can't be pulled down. Keeping hot liquids like coffee cups without lids or top ramen away from counter edges, and spill-resistant travel mugs. And then also close child supervision, so having enforcing kid-free areas in the kitchen so that they are not near those hot stove tops or hot liquids. So that concludes our didactic for today. Again, we'll have an area time for questions regarding the didactic.